Hi, and welcome to the Urgent Care Basics podcast. We really appreciate all your reviews and feedback we've gotten. If you could rate or review us on iTunes or whatever podcast platform that you listen to, we'd really appreciate it. Also, you can follow us on Instagram at Urgent Care Basics or on Facebook at Urgent Care Basics as well. And you can also leave a comment on urgentcarebasics.com. So today's topic will be discussing shingles. All right, but first, here is the pop quiz. From what embryonic layer does the dermatoma come from? A, endoderm, B, ectoderm, C, mesoderm, or B, epiderm? And we'll be back with the answer later. Take it away, Urgent Care Doc.
Hello, and we're back today. On today's show, we'll be discussing shingles. And let's get started with some of the epidemiological information. And this is important. I feel like in the last couple of months, I've seen more than a couple cases a week of this. And I think it's the amount of stress everybody's in that's causing this, that's maybe decreasing their immune systems. But I've seen 3 or 4 cases a week of this, which is really odd. Usually 1 or 2 a week is more the norm, but I feel like I've seen more for some reason, which has prompted me to come up with today's topic, shingles. It appears that about 1 million cases of zoster occur in the U.S. yearly. Your individual risk of getting it is 30%. Usually it's associated with having had chickenpox as a kid. The virus is the varicella zoster virus. Once again, it's also the one that causes shingles. So if you had chickenpox as a kid, generally you'll have a decent risk of developing shingles as an adult. And the risk does increase as you get older, as immunity wanes. The other risk factors that make you higher risk for developing is immune modulating medications. So if you have somebody who is taking one of these immune modulating medications for Crohn's disease, ulcerative colitis, like severe eczema or psoriasis, or somebody who is immune compromised for something like HIV, then these patients will be at higher risk for developing shingles. So keep that in mind when taking your patient history. Like I mentioned earlier, this is a disease that kind of is a 2-phase disease. In your childhood, you develop chickenpox and your body's able to kind of knock it down. After that initial infection, what happens is the virus travels to the cranial and dorsal root ganglia, where they're behind the blood-brain barrier, where your immune system is a little more or has a harder time getting to it, but it sits dormant. And generally, your immune system can keep this in check. But as we all get older, the immunity does wane. So you end up having a harder time keeping it at bay. And at the times when you're stressed or your immune system is decreased for one reason or another, the virus will kind of reappear in the form of shingles. Some of the symptoms that occur before the classic rash appears can be feeling fatigue, malaise, tired, having headache or fever. And then one of the prodromal, pre having the full-on case of shingles is you'll have people complain of skin sensation that is abnormal, whether it be very sensitive. Oftentimes, some people have described it to me as having like a sunburn. So it's very sensitive, tender, and then a couple of days later, the actual blisters from shingles will pop up. And if you haven't seen shingles before, it's a very specific rash. It's a kind of maculopapular lesions, vesicular in nature. All that means is they look like little blisters, little bubbles, and they usually start off as clear vesicles. And somewhere a couple of days in, they start to kind of burst. They weep. Then you end up getting a crust on the lesion. And once the lesions are crusted over, you're getting closer to finishing the course of the illness. So keep that in mind. However, medication should be started within 72 hours of the initial outbreak. It is recommended that you still give it to them after the initial outbreak, as it helps decrease the risk of the complications of shingles. One other key factor that occurs with shingles, it's the rash is unilateral most of the time. Can it cross? So unilateral meaning if it's on the left arm, it tends to be on the left arm, and it follows a dermatomal distribution. So usually you have a patch of skin that it follows through, and oftentimes, let's say you have a lesion on the lower, like by the forearm. Usually if you chase the dermatome, and you'll have to look it up because there's multiple dermatomes for each body part, you'll chase it up the dermatomal line, and you can kind of touch the skin along the dermatome, and people will complain of increased sensitivity, tenderness, or pain. One other kind of tip when you're examining any of these rashes, please wear gloves, especially in a vesicular rash that you are considering is shingles. That clear discharge is very contagious. So you want to keep that in mind when you're doing your physical exam. If anybody tells you, hey, I have these little bubbles or blisters, get some gloves, because that stuff is very contagious.
And here is the answer to the pop quiz. The answer is C, mesoderm. Dermatomes arise from the mesoderm, which also gives rise to the spinal cord and nerves. And here we go, back to the podcast.
So as per usual, examining, usually it's one-sided, unilateral, and rarely or not often does it cross midline when you're in the abdomen or torso. So the classic kind of symptom or complaint is kind of mid-abdomen or chest, and it goes from mid-abdomen to the mid-back, and it doesn't cross the midline. So if you have somebody that's complaining of that, obviously you have to treat them. So keep that in mind. Once again, make sure you're wearing your gloves when you're examining any of these skin lesions. The thing to keep in mind with this rash is the differential with blistering rash is can be wide, but you should always consider contact dermatitis. So in your history, you're checking that the patient hasn't been out camping or any one of those things to make sure it isn't a contact dermatitis. You also want to make sure that it's not impetigo or eczema herpeticum, which can also look like a blistery rash. So keep those differentials in mind when you're seeing a blistery rash. So now that you have determined, yes, this is unilateral, yes, this is a blistery rash, yes, this follows a dermatome, yes, this is also followed or had previous symptoms of fatigue, tiredness, malaise, any kind of fever, and you're sure this is shingles, the treatment options are actually quite limited. So you have 3 medications that are usually used for this as far as treating the symptoms. So you have acyclovir, valacyclovir, and famaciclovir. So all those 3 options are available to you. Acyclovir, I think, is the one you take the more highest frequency. So patients end up taking it 5 times a day. So keep that in mind. If somebody is already on 5 medications and you're going to throw another medication at them that they have to take 5 times a day, keep that in mind for compliance, as taking anything 5 times a day is kind of hard. And the reason you want to start the medications is because the use of these medications help prevent a kind of issue that occurs after the rash is gone, and that is called post-herpetic neuralgia. And that is pain, discomfort, and burning in the region where the rash was for greater than 90 days. And it occurs in 20% of the people that have had shingles. So keep that in mind. You want to treat it even if it's greater than 72 hours, because it helps decrease the risk of this quite debilitating, uncomfortable condition called post-herpetic neuralgia. And the reason this occurs is because as the virus is replicating along that dermatomal line, along those nerves, it can damage the nerve itself, and therefore you have this kind of constant or chronic pain, discomfort due to some neuropathy. And if you have a patient who has post-herpetic neuralgia, you also want to consider treating them with whether it be gabapentin, pregabalin, or amitriptyline. In the initial treatment of shingles, you do want to consider something for the pain, as this could be quite uncomfortable, and those are decent options as well. NSAIDs work, Tylenol works for the initial stages, so keep that in mind when treating these patients. Follow-up for these patients should include a visit with their primary care provider, and if they're over the age of 50, the shingles vaccine is highly recommended in order to prevent, 1, having a recurrence, and 2, having the complications of post-herpetic neuralgia that can last up to 90 days but can be indefinite, so it helps prevent that long-term side effect or consequence of having shingles. All right, so I think for the most part, that covers shingles. It's a short show today. Thank you for listening, and we appreciate your feedback on the previous episode, which was the case presentation. We will try to incorporate one of those a month, and hopefully you guys enjoy what we're putting out. Otherwise, stay safe and have a great week.
And here are today's clinical pearls. Number 1, vesicular rash can have a broad differential diagnosis. It can be caused by shingles, contact dermatitis, or eczema herpeticum. Number 2, antivirals used to treat shingles are acyclovir, valacyclovir, or famciclovir. Number 3, use gloves when examining any vesicular rash. Number 4, post-herpetic neuralgia can occur in 20% of people who have shingles. Number 5, shingles vaccine is recommended for people over 50 years old. All right, so that's our podcast for today. We hope you enjoyed it. Once again, if you can follow us on Instagram at urgentcarebasics.com, Facebook at urgentcarebasics.com, and at urgentcarebasics.com. We appreciate you guys for listening. We hope you have a good day. Stay safe out there, and we'll talk to you next time.